Yeomans and Nguyen, Section 1, Introduction to Neurosurgery, Part 3, Overview of Radiology, Chapter 10, CT and MRI of the Brain. Hello, I'm Dr. Thomas Kim from St. Louis University School of Medicine and the senior author for this chapter. Chapter 10, CT and MRI of the Brain. This chapter covers a broad subject material, and because of that, by necessity, it's a survey chapter where we cover multiple subtopics including MRI physics, intracranial hemorrhage, neoplasms, infections, aneurysms and vascular malformations, stroke, and epilepsy. In a separate presentation, Dr. Prost, our co-author and an MRI physicist, will provide an excellent presentation on MRI physics to include the fundamentals of MRI imaging, MR spectroscopy, perfusion MRI, diffusion tensor imaging. In this presentation, I will cover 4 major areas within the chapter, including intracranial hemorrhage, aneurysms and vascular malformations, common CNS neoplasms, and cysts, and imaging strategies for acute stroke. Imaging of hemorrhage. Intracranial hemorrhages are typically described based on the space in which the hemorrhages are found. So we have epidural and subdural hemorrhages, subarachnoid hemorrhages, intraventricular hemorrhages, and parenchymal hemorrhages. Epidural and subdural hemorrhages are most commonly caused by trauma and rarely as post-surgical complications. Parenchymal hemorrhages have many potential etiologies. Most commonly it's due to hypertensive disease or amyloid angiopathy in the elderly, and commonly from closed brain injuries. AVMs and aneurysms can be also associated with parenchymal hemorrhages, along with high-grade primary neoplasms like GBM and metastases, infarctions including vasculitis and encephalitis. Intraventricular hemorrhages are typically a secondary phenomenon with extension of hemorrhage from adjacent tissues caused by hypertension, AVM, aneurysm, or germinal matrix hemorrhage in neonates. Subarachnoid hemorrhages are most commonly due to trauma. The most common non-traumatic cause for subarachnoid hemorrhage is a rupture of a brain aneurysm. Occasionally, subarachnoid hemorrhages can be seen with AVM rupture, and there is a special entity called benign perimesencephalic hemorrhage, where a small amount of subarachnoid hemorrhage is visualized typically around upper brainstem without any definite aneurysm or AVM being discovered on follow-up imaging, including cerebral angiography. Imaging modalities which are used to assess patients who present with acute intracranial hemorrhage include computed tomography and MRI, including CT angiograms, diffusion, perfusion MRI, and MRA, as well as the DSA, conventional catheter angiography. CT is usually the first study, with the head CT without contrast being obtained, with multiple windows, such as brain, blood, and bone windows, for assessment of parenchymal pathologies, parenchymal hemorrhages, extraaxial hemorrhages, and fractures. CT angiogram can also be obtained in certain patients where high-resolution images are obtained to assess for both the arterial and venous anatomy. And head CT with contrast can be obtained following a CTA to assess for any enhancing pathologies or masses. MRI can also be used in certain patients to assess for intraparenchymal pathologies. MRA can be used to assess for arterial pathology, including aneurysms and AVMs. MR venogram can be used to assess for, again, for AVM, as well as any major dural sinus thrombosis or stenosis. Gradient echo and SWI imaging can be helpful to identify small foci of parenchymal hemorrhages. As mentioned earlier, epidural and subdural hemorrhages are most commonly caused by trauma and rarely by surgery or post-surgical complication. Traumatic brain injury is a leading cause of death and disability in the United States. According to data from CDC in 2014, approximately 2.8 million ED visits, admissions, and deaths were due to traumatic brain injury. And in that year, traumatic brain injury was diagnosed in close to 300,000 hospitalized patients, leading to death in over 56,000 patients. Between 2006 and 2014, ED visits due to potential traumatic brain injury increased by 54%. CT is a study of choice for primary evaluation, with additional CT and MRI, which can be used for further patient management. Here we have a patient who had an acute trauma to the left side of the head and developed a acute subdural hematoma along the lateral convexity of left cerebral hemisphere, which is better visualized on this blood window where the density of the brain is reduced and the acute subdural hematoma is much better visualized along the inner table of the calvarium. This is another patient who demonstrates a phenomenon known as a coup contra coup injury, where there was injury to one side of the head followed by injury to the contralateral side. And we see areas of some parenchymal hemorrhages, small extraaxial hemorrhages along the lateral convexity of the temporal lobe, with a large area of scalp edema and hematoma on the contralateral side. This patient also demonstrated additional areas of parenchymal hemorrhages and minimally depressed fracture involving right temporal bone. Again, showing coup and contra coup injuries with parenchymal hemorrhages. Different patient with a mixed density right-sided holohemispheric subdural hematoma causing a significant mass effect on the right cerebral hemisphere and the midline shift to the left, causing a significant entrapment of the left lateral ventricle. So this patient also demonstrates an onco herniation along the mesial aspect of the right temporal lobe, compressing the midbrain, and it was known as a self-faulting herniation in the midline. This is a patient who presented with an acute epidural hematoma, where the hemorrhage demonstrates a biconvex or lenticular shape with a mass effect on the lateral aspect of the right cerebral hemisphere. It is associated with a non-displaced or non-depressed right temporal bone fracture. This slide shows an acute epidural hematoma along the left lateral hemisphere convexity with biconvex epidural hematoma, with some of the hematoma demonstrating isointensity, suggesting a hyperacute clot with mass effect on the left cerebral hemisphere, causing left oncoherniation with compression of the upper brainstem. Following decompression of the epidural hematoma with only minimal residual postoperative air and hemorrhage and fluid collection along the lateral convexity, one now notes some areas of discrete hypodensity within the left thalamus, as well as developing hypodensity with loss of gray-white matter differentiation involving visualized left inferior paramedian parietal as well as superior paramedian occipital lobes. 2 days later, follow-up PET CT better demonstrates evolving areas of acute infarction within the left thalamus and within the left posterior cerebral hemisphere, and small areas on the contralateral side. And this is due to compression of the left posterior cerebral artery by the uncal herniation caused by the original epidural hematoma, causing acute infarctions within left posterior cerebral artery territory. This is an example of an acute and chronic subdural hematoma where patient most likely had bilateral chronic subdural hemorrhagic fluid collections with acute recurrent hemorrhage on the left side, causing demonstration of hyperdense collections along the dependent portion of the fluid collection with mass effect on the left cerebral hemisphere and a mild subfalcine herniation. This is an example of subtle bilateral isodense subacute subdural hematomas causing mass effect on the lateral convexities of the superior cerebral hemispheres bilaterally. And because the subdural hematomas are bilateral, there is not significant midline shift in this patient. But we see a partially visualized ventricular catheter via right parietal approach. Now we'll move on to a discussion about subarachnoid hemorrhages caused by aneurysms. They typically occur in the region of circle Willis, but rarely they can also occur as mycotic aneurysms involving more peripheral arterial branches associated with systemic infection or endocarditis, or aneurysms associated with AVMs can also lead to subarachnoid hemorrhages. The most common locations for development of Barry-type brain aneurysms involve the origin of the posterior communicating artery, as well as other segments within the supraclavicular ICA, anterior communicating artery, MCA bifurcation, and less commonly involving the posterior circulation at the basal artery terminus, at the origins of pica, anterior and inferior cerebral artery, and superior cerebral artery. Neuroradiology evaluation for aneurysms would start with the head CT without contrast to document presence of an acute subarachnoid hemorrhage, a CTA obtained from skull base to vertex, and a head CT with contrast to follow, and a three-dimensional reconstruction of the CTA data, and when necessary, followed by a conventional catheter angiography with digital subtraction technique. Here's an example of a patient who presents with an acute subarachnoid hemorrhage within the suprasellar cistern, anterior aspect of the Sylvian fissures, within the interhemispheric fissure, small amount of hemorrhage within the left occipital horn as well. These are 4 images magnified from a CTA source image data set which demonstrate a small aneurysm in the region of the anterior communicating artery. This is a 3-dimensional grayscale reconstruction image which demonstrates slightly irregularly shaped lobulated aneurysm arising from the anterior communicating artery, which was the source of the acute subarachnoid hemorrhage. This is a different patient who presents with a subarachnoid hemorrhage who then fell and hit her head. And so the patient also has some parenchymal hemorrhages in the anterior inferior pyramidal and frontal lobe on the right side with surrounding edema, with fairly extensive subarachnoid hemorrhages within the interhemispheric fissure and Sylvian fissures, along with small intraventricular hemorrhage within the right occipital horn. This patient also had an anterior communicating artery aneurysm on CTA, and a 3-dimensional reconstruction image nicely demonstrates an irregularly shaped aneurysm with a small daughter sac or daughter aneurysm, which may be the source of the rupture. Different patient who presents not acutely, but likely subacutely with evidence of cerebral hemorrhage, which is not quite as dense as the cases we have just seen. And patient is noted to have a large aneurysm arising from the right supraclavicular ICA. Three-dimensional reconstruction images nicely demonstrates a large posterior communicating artery aneurysm. As noted previously, parenchymal hemorrhages can be caused by multiple etiologies, most commonly associated with hypertension. One of the more common causes in the elderly patient is due to amyloid angiopathy. Trauma can present with parenchymal hemorrhages along with epidural or subdural hemorrhages or subarachnoid hemorrhages. When AVM ruptures, AVMs can give not only subarachnoid hemorrhages but also a sizable parenchymal hematoma associated with it. Aneurysms typically present as subarachnoid hemorrhage as the dominant picture, but can be associated with some smaller parenchymal hemorrhages if the jet of the hemorrhage dissects into the parenchyma adjacent to the aneurysm. We also mentioned that neoplasms, especially high-grade primary gliomas and metastases, can be associated with hemorrhages and infarctions and encephalitis. In the setting of hypertensive hemorrhage, the most common location is the basal ganglia, typically globus pallidus and putamen. Thalamus is the next most common in the supratentorial brain. And within the infratentorial brain, pontine hemorrhage is common, with less common locations in cerebellar hemispheres and then subcortical white matter. Here we have two different cases of a patient with a posterior fossa parenchymal hemorrhage, which extends into the right middle cerebellar peduncle, and a large hematoma that involves thalamus on the left and likely extending into the posterior aspect of the lenticular nuclei as well. This is an example of a very large right-sided thalamic and basal ganglia hemorrhage. It's associated with intraventricular hemorrhages in the third ventricle and lateral ventricles bilaterally, and a subfalcian herniation to the left. It's causing asymmetric entrapment of the left temporal horn. There's also some hemorrhage extending into right cerebral peduncle. This is another patient with a very large right basal ganglia hematoma with a mass effect on the right lateral ventricle and subfalcian herniation. And literature has shown as the size or the volume of the acute hematoma increases, there's a good correlation with poor clinical outcome. This slide demonstrates a large left basal ganglia hemorrhage with intraventricular extension. It also demonstrates irregular areas of hyperdensity within the hematoma, and they represent extravasation of contrast and active bleeding. And this is sometimes called a CT angiographic spot sign, and they bode poorly for clinical outcome for patients since they represent active continuous bleeding into a large hematoma. Hemorrhagic transformation of an infarction is another cause for parenchymal hemorrhages, and they occur in early subacute stage of an acute stroke. Hemorrhagic conversion is seen in as many as 70% of patients who present with cardioembolic strokes and about 30% of all ischemic strokes. Primary hematomas, as we've seen with hypertensive hemorrhages, tend to be more homogeneous in density, round to oval in shape, and more sharply defined than hemorrhagic infarcts, which tend to be more heterogeneous and irregularly shaped. Here's an example of a venous infarction with hemorrhagic components within it. There are some subtle areas of increased T1 signal intensity on this MRI images without contrast, and T28 images demonstrating some areas of isointensity to slight hypointensity, representing acute hemorrhage within this infarction. As noted earlier, amyloid angiopathy can lead to hemorrhage commonly in the elderly patients. They tend to be more lobar in location, meaning more within the frontal lobes or parietal lobes, and peripherally in location, as opposed to basal ganglia or thalamic hemorrhages or pontine hemorrhages, which are seen with hypertensive hemorrhage. And they are due to age-related small vessel angiopathy, and many of these patients are often on anticoagulation therapy, and that also puts them at a higher risk for developing acute hemorrhages. This is a patient who presents with the right frontal lobe parenchymal hematoma with varying ages of the hematoma component on the MRI images, surrounded by areas of edema. And this is due to an underlying vasculitis, which resulted in development of a parenchymal hematoma. Cerebral angiography on this patient demonstrates multiple arteries with irregular contour and what's known as beading appearance, with areas of alternating dilatation and stenosis within this PCA branch, as well as multiple MCA branches and distal ACA branches. Intraventricular hemorrhages, as I noted previously, usually represents a secondary phenomenon, although one could develop isolated primary intraventricular hemorrhages associated with intraventricular vascular pathologies or neoplasms. Typically, they represent a secondary hemorrhage with extension of hemorrhage from adjacent brain tissue. In this patient, the patient presents with hydrocephalus with intraventricular hemorrhages, as well as subtle areas of abnormal density in the region of the left paramedian occipital lobe. Post-contrast images nicely demonstrate a large left occipital lobe arteriovenous malformation with abnormal blood vessels along the mesial aspect of the left temporal lobe and multiple abnormal draining veins along the cortex. This is an MRI from a neonate, and it demonstrates asymmetric signal within the left lateral ventricle, which is hyperintense on T1 weighted images and hypointense on these T2 weighted image, on this T2 weighted image. And this is an example of a grade 4 germinal matrix hemorrhage in a neonate with bilateral intraventricular hemorrhage, more on the left side, with extension of the hematoma. The risk factors for germinal matrix hemorrhage includes prematurity, cardiopulmonary disease, and hypoxia or birth asphyxia. Hemorrhages can also be caused by neoplasms, and just about any tumor can be associated with hemorrhage, but they're more commonly observed with high-grade gliomas such as GBM and metastatic disease, especially lung, breast, renal cell carcinoma, and melanoma. When a dominant hematoma is visualized on the initial imaging of the brain, a follow-up MRI without and with contrast should be obtained to make sure that there is no underlying mass that may have been the cause for the original hematoma. This may take days to weeks for the hematoma to decrease or resolve before the follow-up MRI can be obtained to better visualize the underlying mass. Here's an example of a patient who presents with a heterogeneous signal intensity right frontal lobe mass with areas of T1 hyperintensity and hypointensity, as well as a large area of central T2 hypointensity consistent with acute hemorrhage. This patient presents with multiple small enhancing parenchymal lesions within anterior temporal lobes bilaterally with a large areas of surrounding facial edema. There's likely also a metastasis within the superior vermis with associated edema. And this patient was discovered to have a large right renal cell carcinoma. Hemorrhagic metastases can be seen with lung and breast cancers because they are two of the more common primary cancers which metastasize to the brain. Certain histologic types such as renal cell carcinoma, melanoma, thyroid carcinoma, and choriocarcinoma are far less common, but they are known to be more commonly associated with hemorrhagic metastases. Switching gears a little bit, we have two T2-weighted axial images through the posterior fossa, and the primary findings are abnormal opacification of the right mastoid on both of these images, a hint of a somewhat serpiginous vascular structure that's slightly hyperintense on these T2-weighted images. On these T1-weighted images, they all again demonstrate area of opacification of the right mastoid, and these areas of T1 hyperintensity in the region of the right sigmoid sinus and right jugular fossa, and higher up in the right posterior temporal lobe, irregular area of precontrust T1 hyperintensity. On these T2 flare-weighted images, one sees larger area of parenchymal edema with some heterogeneous signal intensity where there was pre-contrast T1 hyperintensity, and here is a post-contrast T1 weighted axial image demonstrating irregular gyriform enhancement. Post-contrast coronal T1 weighted images again demonstrate the area of parenchymal signal intensity abnormality with gyriform enhancement, but it also shows an apparent filling defect within the right transverse sinus surrounded by enhancing dura. MR venogram nicely demonstrates absence of normal flow signal within the right transverse and sigmoid sinuses and right jugular fossa compared to the normal contralateral left side. And this is a coronal reconstruction images again demonstrating absence of normal venous flow signal within the right transverse and sigmoid sinuses into the right jugular vein. So this is a case of a transverse sinus thrombosis. In fact, it's more than transverse sinus. It's transverse sinus and sigmoid sinus thrombosis due to mastoiditis, and the venous sinus thrombosis led to venous infarction, and such findings can be seen as complications of not only infections, but trauma or surgery or neoplasm. This patient presents with headache and fever. An MRI without contrast demonstrates an area of abnormal hypointensity within left anterior temporal lobe with hyperintensity along its lateral aspect, and a T2 image demonstrating generalized increased signal intensity in the same area consistent with edema. This is an example of a patient with herpes encephalitis, which is a reactivation encephalitis in adults where the virus that remains dormant within the trigeminal ganglia are reactivated and infect the adjacent temporal lobe, leading to encephalitis. They're often hemorrhagic. Patients frequently present with seizures, and this entity is associated with high mortality if not identified early and treated. In neonates, where they may present with primary infection, the encephalitis is more generalized within cerebral hemispheres and are not localized to the temporal lobe as they are in adult patients. Now we'll go on to speak about vascular malformations of the brain. There are four main types of congenital vascular malformations that are found in the brain. First is arteriovenous malformation, which is the only high-flow vascular malformation. The others are all low-flow vascular malformations, and they include cavernous malformation, capillary telangiectasia, and development of venous anomaly. Arteriovenous malformations are composed of feeding arteries, nidus, enlarged veins, without associated normal capillary bed or parenchyma. In about 10 to 12% of these AVMs are associated with feeding artery aneurysms. Calcification can be sometimes seen as dystrophic calcifications within adjacent tissue with chronic ischemia. They're usually solitary, but can be multiple in certain syndromes such as Wyburn-Mason and Osler-Weber-Rondeau. Hemorrhage can be seen up to 50% of patients with AVM, with hemorrhagic risk of 2 to 3% per year. And they demonstrate prominently abnormal findings on cerebral angiography. Here's an example of a patient that we've seen before that presented with a left occipital lobe AVM with a large nidus and abnormal vessels along the mesial aspect of the left posterior temporal lobe, as well as likely abnormal cortical draining veins along the left posterior temporal lobe and inferior parietal lobe. This is a left internal carotid artery angiogram image which demonstrates abnormally enlarged branches of left middle cerebral artery, providing blood flow to the AVM in the inferior parietal and occipital lobes, and an AP view demonstrating large capillary blush in the region of the AVM with enlarged draining veins. Same patient with a left vertebral artery injection now demonstrates arterial flow to part of the AVM from distal branches of left posterior cerebral artery with oily draining veins visualized on this lateral view. Cavernous malformations are lobulated sinusoidal vascular spaces which are endothelial lined. They frequently demonstrate hemorrhages of varying ages resulting in heterogeneous signals on MRI images. In 50 to 80% of the patients, these lesions are multiple. They are not visualized on angiography because it's a low-flow vascular lesion. Calcifications are common, and they can coexist with other vascular malformations such as a development of venous anomaly or sometimes capillary telangiectasia. T2-weighted images demonstrate a focus of hypointensity adjacent to left frontal horn and a larger, more complex appearing lobulated lesion within left parietal lobe with peripheral hypointensity and central hyperintensity with some associated parenchymal edema. This is an example of multifocal cavernous malformation in this patient. Here's a different patient, again demonstrating heterogeneous signal intensity with areas of T2 hyperintensity and some peripheral hypointensity, as well as T1 hyperintensity and some associated hypointensity involving right medial cerebellar hemisphere with extension into the posterior aspect of right middle cerebellar peduncle. Capillary telangiectasia typically are even smaller than cavernous malformations, often difficult to recognize on imaging, and they represent nests of dilated capillaries. They are almost always incidental, and apparently they are second most common finding in autopsy. There are a couple of different subtypes of capillary telangiectasias histologically. They can be found anywhere, but often in pons, cerebellum, and spinal cord, kind of locations where it's difficult to actually confirm by histology in patients. Angiograms are normal because, again, this is a low-flow vascular malformation and typically very small. They can coexist with other vascular malformations such as cavernous malformations or development of venous anomaly. It is believed by some that these vascular malformations, cavernous malformations, capillary telangiectasias, development of venous anomalies, and AVMs represent a spectrum of vascular pathology rather than distinct entities. Development of venous anomaly, which is what its current name is, had other names in the past. They were called venous angiomas or venous malformations. Histologically, they are dilated venous channels draining normal brain. The appearance of the lesion is such where you have multiple smaller veins draining into a larger draining vein. It reminded some people of the figure from Greek mythology, Medusa, with multiple snakes arising from her head, or the caput Medusa. They can coexist with cavernous malformations and capillary telangiectasias. They are found anywhere, but often along lateral ventricles, and can be found in cerebellum or cerebral hemispheres, typically in the frontal lobes. Unlike the other low-flow vascular malformations, development of venous anomaly can be visualized in cerebral angiography in late venous phase due to the dilated and prominent veins. Here's an example of a patient with a cerebellar development of venous anomaly with multiple smaller veins drain to a larger vein which extends and then drains into a cortical vein. Post-contrast T1 weighted images demonstrate again multiple small branching veins draining into a larger vein along the wall of the fourth ventricle. Late venous phase images from cerebral angiography in AP and lateral views nicely demonstrate these multiple small venous tributaries draining into a larger draining vein, then eventually into the medial aspect of the right transverse sinus. And this is the appearance that people talk about as caput medusa. It's a very classic example of a development of venous anomaly. This is a case we saw earlier with a cavernous malformation within the right cerebellar hemisphere extending into the posterior aspect of the right middle cerebellar peduncle. And slightly lower down, this patient has a coexisting development of venous anomaly, which is best visualized in post-contrast T1 weighted images. Now we'll discuss brain neoplasms and cysts. This pie chart nicely demonstrates an approximate distribution of various subtypes of primary tumors in the brain, with the gliomas representing about half of the primary tumors, meningiomas 15%, pituitary adenomas about 5%, and primitive neuroectodermal tumors representing about 6 to 8%, 3% for craniopharyngioma, 6% for schwannoma, most of them being the vestibular schwannoma involving the 8th cranial nerve, small percentage of lymphomas and hemangioblastomas. 2016 WHO classification of the brain tumors include multiple subgroups, with the largest group being the diffuse astrocytic oligodendroglioma and other astrocytic tumors, with 27 distinct neoplasm types, ependymomas with 7 subtypes, choroid plexus tumors, and other gliomas, 13 different types of neuronal and mixed neuroglial tumors, embryonal tumors including 11 subtypes of medulloblastomas, nerve sheath tumors which include 12 subtypes, 16 subtypes of meningiomas, 26 types of mesenchymal tumors, melanocytic tumors, lymphomas, histiocytic tumors, and tumors of germ cell origin, tumors arising from satellite region and pineal region, and finally, cysts and other tumors. The total comes to around 169 separate tumor types and cysts, and obviously we're not going to be covering all of them in this presentation or in the book chapter, but we will go through some of the more common ones one will encounter. So start with gliomas. They represent about 40 to 45% of all brain tumors, with peak incidence in the 7th decade. Majority of them are supratentorial in location in adults. However, in children less than 2 years old, 70 to 80% are in the posterior fossa. Within the diffuse infiltrating glioma group, astrocytomas are the most common. They are commonly associated with IDH mutation in their grade 2 and grade 3 astrocytomas. Oligodendrogliomas also have IDH mutation, but they also are found to have 1p19q co-deletion. So any diffuse infiltrating glioma that meets the criteria of both IDH mutation and 1p19q co-deletion are by definition oligodendrogliomas. Glioblastoma multiformes come in two different subtypes. The secondary type, which most likely arose from degeneration of a previous low-grade tumor like oligodendroglioma or astrocytoma, will have IDH mutation, while primary glioblastoma multiforme are typically IDH wild type. Astrocytomas represent approximately 30% of all gliomas. They are a heterogeneous group of tumors from well-differentiated low-grade tumors to poorly differentiated high-grade tumors. Survival is between 3 to 10 years for low-grade to 2 years for anaplastic and 1 year for GBM. Variable histology within a given tumor with frequent dedifferentiation are seen among these astrocytomas. Low-grade astrocytomas are typically well circumscribed with little edema with no or mild enhancement. Cysts and calcifications can be seen. They are rarely infiltrating with poorly defined borders. They are hypo to iso-intense on T1 and iso to hyperintense on T2 with images. They may show mild increase in choline amplitude or concentration and decrease in NAA on MR spectroscopy. These images demonstrate a predominantly cystic mass within left cerebellar hemisphere with an enhancing mural nodule associated with prominent non-communicating obstructive hydrocephalus in a child. And it's an example of a cerebellar astrocytoma. It is well circumscribed but unencapsulated mass, commonly of pilocytic variety. Cysts are common with enhancing mural nodule with variable degree of enhancement, and is typically a low-grade tumor with no or little edema. Pilocytic astrocytomas are typically found involving the optic apparatus, the hypothalamus, involving the cerebellum, and they are known to have good prognosis, but occasionally they are known to spread via CSF throughout the CNS system. Histologically, they display Rosenthal fibers, which are astrocytic inclusions of ductal crystalline. That the reason why they are called pilocytic astrocytoma is that these cells with cytoplasmic processes resemble hair on a touch prep. These are coronal T2 images demonstrating enlarged optic nerves within the orbital apex, as well as involving the intracranial segments of the optic nerves heading toward the optic chiasm. X-ray images demonstrating enlarged optic nerves through the optic canals into the intracranial compartment, as well as enlargement of the region of the optic chiasm and optic tracts on these post-contrast T1 ray images. This is an example of one of those rare pilocytic astrocytomas with CSF seeding, where prominently enhancing mass is present within the suprasellular cistern, but there are extensive areas of enhancement within the subarachnoid spaces, consistent with CSF spread of the pilocytic astrocytoma. We can also see on these axial T1 weighted images through the spine and sagittal T1 weighted images demonstrating diffuse CSF seeding of the astrocytoma. On these images, we see enhancing masses adjacent to the region of the foramen Monroe along the inferior aspect of the frontal horn bilaterally, consistent with giant cell astrocytomas. We can see the larger of the two lesions on sagittal post-contrast T1 weighted images here, and T2 weighted images demonstrate multiple irregularly shaped cortical T2 hyperintense lesions consistent with cortical tumors in this patient with tuberous sclerosis. Grade 2 diffuse astrocytomas demonstrate a high degree of cellular differentiation with slow growth pattern and diffuse infiltration. They're typically found in young adults and children and demonstrate some tendency for malignant transformation. They represent approximately 10 to 15% of all astrocytomas with slight male predominance. Within the supratentorial brain, they are typically found within frontal and temporal lobes, with the brainstem and spinal cord being next most common. They are uncommon in the cerebellar hemispheres. They demonstrate diffusely infiltrating features within a background of normal white and gray matter with normal oligodendrocytes. They demonstrate slight premorphic enlarged nuclei, and they are MIB positive. These images demonstrate a poorly defined T1 hypointense lesion without much enhancement arising from left temporal lobe with extension through the anterior aspect of the left temporal stem with localized mass effect and a predominantly hyperintense lesion on T2 images. Higher grade astrocytomas demonstrate more heterogeneous cellular intensity and characteristics with shape with ill-defined margins and enhancement pattern. They are likely to demonstrate certain areas of necrosis and hemorrhage with variable degrees of vision edema. On MR spectroscopy, higher grade astrocytomas typically demonstrate elevated choline concentration with decreased NAA and may show lactate consistent with anaerobic metabolism and mobile lipids consistent with necrosis. This axial T1 weighted images with contrast demonstrate a complex cystic and solid mass with peripheral enhancement and a heterogeneous enhancing solid component along its posterolateral aspect, which was proven to be a grade 3 astrocytoma. Histologically, these tumors demonstrate focal or dispersed anaplasia and demonstrate high proliferative potential. They're typically found in adults with slight male predominance, and they have tendency for malignant transformation. These anaplastic astrocytomas again demonstrate increased cellularity, nuclear atypia, and marked mitotic activity, and are shown to be IDH1 mutant. These sets of T2 flare and post-contrast T1 axial images demonstrate a large mass with T2 flare hyperintensity, which is centrally necrotic with peripheral enhancement involving the region of the anterior body of left cingulate gyrus, which was shown to represent a necrotic glioblastoma multiforme. It is a WHO grade 4 tumor, which demonstrates prominent pleomorphism with severe nuclear atypia and mitotic activity, with evidence of microvascular proliferation as well as endothelial proliferation with necrosis and heterogeneous histological features. Secondary GBMs are known to be IDH1 mutants commonly, while primary GBM are almost always wild type. T2 axial images demonstrate a heterogeneous signal intensity mass involving right occipital lobe with extension into the right parietal periventricular deep wide matter and involving the spleen with the corpus callosum with very much heterogeneous enhancement pattern on post-contrast T1 weighted images. This study demonstrates a 2D MR spectroscopy or chemical shift imaging where one can generate multiple matrices of MR spectra through a whole region of a hemisphere to include the areas of pathology and also obtain data simultaneously from contralateral hemisphere where we can see normal concentration of NAA, which is the dominant peak here, with normal concentrations of creatine and choline. Whereas in the areas where there are tumor infiltrations involving the spleen of the corpus callosum and periventricular white matter, we can see abnormal spectra with dominant choline concentrations with diminished NAA peaks or NAA concentrations. And then in the areas of necrosis, we see a paucity of metabolite peaks. The same MR spectroscopy data can be post-processed to generate various metabolite color maps. And here on the left, we have a choline map, again demonstrating areas of elevated choline concentration in the area of the tumor involving the spleen of the corpus callosum and periventricular white matter. This is a color map from a perfusion MRI, which demonstrates elevated blood volume in this area corresponding to the elevated choline concentration MR spectroscopy, consistent with neoplastic process, whereas posterior to it, in the area of central necrosis of the tumor, we do not see significant blood volume at all. In 2015, a paper demonstrated that median disease-free survival correlated well with the cerebral blood flow patterns, where those patients who demonstrated elevated cerebral blood flow had much shorter median disease-free survival compared to those who did not. MR spectroscopy can be also useful in identifying those patients with IDH1 mutant genes, in that these genes result in accumulation of 2-hydroxyglutarate within tumor cells, including gliomas. In vivo detection of 2-hydroxyglutarate at 2.25 parts per million can be obtained with MR spectroscopy, especially at higher field strength MRI scanners. Diffuse midline glioma, used to be called a pontine glioma, represents approximately 10% of all childhood brain tumors. They are shown to be diffuse and infiltrating and sometimes demonstrate subarachnoid spread, and they are proven to be H3K27M mutant with median survival 1 year. They demonstrate variable signal line enhancement with T1 hypointensity or isointensity and T2 hyperintensity. Typically, brainstem is shown to be expanded by the tumor. Tumor often encases the basal artery and also demonstrates exophytic growth, necrosis, and hemorrhage. Here is a T1 weighted satchel images demonstrating enlarged pons with areas of heterogeneous signal intensity, with part of the tumor demonstrating hyperintensity, whereas part of the tumor demonstrates isointensity, and the tumor encases the mid-basilar artery. Here's a different diffuse midline glioma, which demonstrates a prominently hypointense signal with exophytic growth anteriorly, which also encases the basilar artery. And we can see the same tumor on sagittal T1 images with very well circumscribed hypointensity, almost mimicking a cyst. However, this was proven to be a solid tumor. Another diffuse midline glioma with T2 hyperintensity that's pretty much displacing the entire pons. It demonstrates T1 hypointensity on T1 weighted images with prominent enhancement on post-contrast T1 weighted images, proving that it's a solid neoplasm as opposed to a cyst. There are other non-astrocytic gliomas, such as oligodendrogliomas, ependymomas, and choroid plexus papillomas and carcinomas. Oligodendrogliomas arise from oligodendrocytes and are associated with certain genetic defects such as 1p19q co-deletion and IDH mutant gene. It is a tumor of adults with peak incidence in 30s to 50s. They represent approximately 5 to 10% of all gliomas. Approximately 50% are mixed with astrocytomas and recur as a high-grade astrocytoma. Cysts and calcifications can be seen, with calcifications observed in nearly 70% by pathologists, about 30% by radiology imaging. T1 weighted axial images demonstrate slightly heterogeneous but predominantly low signal mass within right inferior frontal lobe with homogeneously hyperintense signal characteristics on T2 weighted images without much surrounding vasogenic edema or mass effect. Here's a different patient with a prominently enhancing superficial cortical and subcortical lesion within left anterior temporal lobe. The next category are tumors of the ependymal origin. WHO classification system identifies 7 distinct subtypes, and they are papillary clear cell tensitic ependymomas, subependymoma, ependymoma which is RELA fusion positive, myxopapillary ependymoma, and anaplastic ependymoma. Ependymomas are typically thought of as being soft and more pliable fourth ventricular masses which demonstrate extension through foramina of Luschka or Magendie. They are of variable cellularity, resulting in variable signal intensity and density on CT, with approximately 10 to 20% demonstrating calcifications. They are more likely to be infratentorial in location, especially in children and adolescents. Extraventricular extension is frequently observed with these tumors. Here is a T2 axial image demonstrating a large mass which appears to arise from the fourth ventricle with predominantly T2 hyperintensity but some heterogeneous internal architecture with evidence of extension through the right lateral foramen Luschka. This is a different patient with similar appearance with T1 weighted images demonstrating slightly hypodense or hypointense mass within the fourth ventricle, with the post-contrast T1 weighted image demonstrating heterogeneous enhancement pattern, and T2 weighted sagittal and post-contrast T1 weighted sagittal images demonstrating an enhancing mass with extension through the midline foramen Magendie through the foramen magnum into the upper cervicospinal canal. Spine MRI images here demonstrate a heterogeneous signal intensity but predominantly isointense to slightly hyperintense mass on T2 images with fairly homogeneous enhancement within the spinal canal at the thoracolumbar junction, consistent with a myxopapillary ependymoma arising from conus medullaris. These images demonstrate a heterogeneous density mass within the left frontal and anterior parietal lobes with multiple areas of hyperdensity likely representing calcifications on this non-contrast head CT. T1, T2 flare, and post-contrast T1 radioaxial images, again demonstrating heterogeneous signal characteristics on all these sequences with areas of patch enhancement. This is a supratentorial ependymoma, as they are likely to be extraventricular and more parenchymal in the supratentorial location compared to the infratentorial ependymomas. 6 to 12% of all pediatric brain tumors are ependymomas, and almost one-third of all brain tumors in patients younger than 3 years of age. The posterior fossa ependymomas arise most often in children. The supratentorial ependymomas generally manifest in an older age group and usually, as seen earlier, extraventricular parenchymal masses. The prognostic factors for these patients with ependymomas include absence of residual disease after surgery, with 60 to 90% 5-year tumor-free survival. Age at presentation is important, with those who present before the age of 3 and those with duration of symptoms less than 1 month having much worse outcome. Survival is better for those who present with supratentorial ependymomas compared to the infratentorial ependymomas. Subependymoma is a low-grade WHO grade 1 tumor, arises from subependymal glial layer. It's typically small, often asymptomatic, and presents as an intraventricular mass, most commonly within the fourth ventricle. Larger symptomatic masses may be associated with hydrocephalus. It demonstrates variable degree of enhancement. Small cysts and calcifications and hemorrhage can also be seen. Approximately 10% contains a small component of ependymoma, and their appearances are very similar to that of ependymoma. Subependymomas tend to be intraventricular, whereas ependymomas tend to be paraventricular or extraventricular in location. None of the imaging features are sufficiently pronounced to be pathognomonic for either lesion. The distinction between these tumors are even less apparent for those that arise in the fourth ventricle. Choroid plexus papillomas are low-grade tumors, with choroid plexus carcinomas being quite rare. Choroid plexus papillomas histologically demonstrate papillae formations over a vascular connective tissue core, and it has been said that they grossly resemble a cauliflower. Lateral ventricular atrium is a typical location in children. Lateral recess to the fourth ventricle is a typical location in adults. These tumors tend to be hyperdense on CT with variable MR signal characteristics. They usually demonstrate prominent enhancement, and calcifications can be found in 25 to 50%. Axial T2 image demonstrates a slightly hyperintense intraventricular mass within the inferior aspect of the fourth ventricle. Sagittal T1 images without contrast demonstrates an isointense lesion, again extending through the inferior part of the fourth ventricle. And an axial post-contrast T1 weighted image demonstrates a prominent homogeneous enhancement of this mass. This is a typical appearance of a fourth ventricular choroid plexus papilloma. In a different patient, there is a larger mass which demonstrates a lobulated contour with prominent enhancement, again within the inferior aspect of the fourth ventricle, extending slightly caudally. Another example of a choroid plexus papilloma. Brain non-glial neoplasms. Next category is embryonal tumor, with medulloblastoma representing the largest subgroup. Medulloblastomas occur mostly before the age of 15 years of age. They arise from germinative cells in the roof of the fourth ventricle and the external granular cell layer of the cerebellar hemispheres. Medulloblastomas tend to be midline and presents as an intraventricular mass in children, but they are more likely to be lateral or hemispheric in adults. There are 11 subtypes of medulloblastomas identified in the latest WHO classification. They frequently demonstrate subarachnoid and perivascular spread. Axial T2A image demonstrates a slightly hyperintense mass with focus of hyperintensity along its posterior lateral aspect arising from the fourth ventricle, with diffusion-weighted image demonstrating slightly increased diffusion signal consistent with its hypercellularity and high nuclear to cytoplasmic ratio. The mass demonstrates isointensity involving most of its mass with small areas of low signal consistent with cystic change. Sagittal post-contrast T1 weighted images demonstrate heterogeneous enhancement pattern of the mass within the fourth ventricle with evidence of some extraventricular extension. T1 and T2A images demonstrate a different mass within the posterior fossa in the midline involving the posterior wall of the fourth ventricle with extension into the medial cerebellar hemispheres bilaterally with slightly heterogeneous enhancement pattern with most of the mass within the cerebellar hemisphere in this adult patient, again representing a medulloblastoma. T1 weighted images pre and post contrast enhancement in a child that demonstrates a large hemispheric mass within the right anterior cerebral hemisphere, which is isointense gray matter on pre-contrast T1 weighted images with prominent enhancement and regional mass effect and subfalcine herniation. This was shown to represent a CNS neuroblastoma. Again, the mass demonstrates isointensity on T2A images due to its hypercellularity. Different patient with more complex signal intensity mass with areas of isointensity peripherally, hyperintensity more centrally, with a cystic component and associated edema involving right posterior cerebral hemisphere, proven to represent an embryonal tumor. The mass demonstrates irregular heterogeneous enhancement pattern. Two CT images demonstrating a midline anterior inferior frontal mass, which appears to be bihemispheric, with areas of discrete low density similar to that of fat, areas of prominent hyperdensity on this non-contrast image consistent with calcification, and the post-contrast axial CT images demonstrating some areas of solid enhancement in this patient with a CNS teratoma. The MRI images again demonstrate the heterogeneity of this mass with very little surrounding edema. Neuronal and mixed neuroglial tumors. T2A axial image here demonstrates a heterogeneous intensity mass within the right cerebellar hemisphere with areas of hyperintensity and isointensity with some cortical striations. Post-contrast T1 weighted coronal image demonstrates no significant enhancement, but it still demonstrates what appears to represent these cortical striations that were seen on the axial T2A images. This was a cerebellar gangliocytoma, also called limit-to-clue disease. It used to be considered a hematomatous lesion, but according to the latest WHO classification, it is considered a low-grade tumor. It is typically found in young adults. It is hypodense on CT, T1 hypointense and T2 hyperintense on MRI images with demonstration of distinctive cortical striations and generally no enhancement. They can be associated with Cowden syndrome, in which case further evaluation for possible breast, endometrial, or thyroid neoplasms should be undertaken. CT images demonstrating a midline mass which appears to rise from the entry aspect of the left lateral ventricle, abutting the septum pellucidum with prominent hyperdensity, slightly higher level, again demonstrating somewhat heterogeneous appearance and density of this mass, definitely arising from the left lateral ventricle. MRI images demonstrate slightly heterogeneous iso to hypointense intraventricular mass, which demonstrate mild enhancement on post-contrast T1 red images, with the medial border of the mass contiguous with the septum pellucidum. T2A images demonstrating predominantly iso-intense mass with some foci of cystic changes, with additional cystic changes in the image higher up. This is a central neurocytoma, WHO grade 2. It arises as a mass within the lateral ventricle. The mass is contiguous with the septum pellucidum along its medial border, but the mass can be extraventricular in location or demonstrates extraventricular extension, and rarely it can be anaplastic and act more aggressively. On CT, the mass tends to be hyperdense and demonstrate calcifications and cysts. On MRI, the mass tends to be iso-intense to gray matter, with generally mild enhancement pattern, with T2 weight images demonstrating cysts and calcifications. Axial T1 weighted images with contrast demonstrate abnormal enhancement along the surface of the visualized brainstem and cerebellar hemispheres, multiple areas of T2 hyperintensity along the surface of the anterior brainstem, as well as involving the region of the vermis and quadrigeminal plate cistern in this patient with diffuse leptomeningeal glioneural tumor. Diffuse leptomeningeal glioneural tumor presents as extensive superficial sarachnoid plaque-like tumor, previously called leptomeningeal oligodendrogliomatosis. They demonstrate superficial small cysts and nodules from expansion and fibrosis of the sarachnoid spaces. 80% have intramedullary spinal cord lesion. Axial T1 weighted image without contrast demonstrates a subtle subcortical area of hypointensity within left infralateral parietal lobe. T2 weighted image demonstrates somewhat irregular, ill-defined areas of hyperintensity with multiple small T2 hyperintense cyst-like areas within the subcortical white matter. Multiloculated vacuolating neuronal tumor of cerebrum is a relatively recently identified tumor which may relate to ganglion cell tumor. It is thought to be low-grade and benign, typically found in the temporal lobe, and associated with seizures. Differential diagnosis would include DNET, ganglioglioma, and hamartoma. Meningiomas arise from meningothelial arachnoid cells with progesterone and estrogen receptors. They represent approximately 15% of primary brain tumors with peak incidence between 40 and 60 years with significant female-to-male predominance. Most are benign. They appear iso to hyperdense on CT and iso-intense on T1 and T2 weighted MRI images, typically with prominent post-contrast T1 enhancement. They can be associated with calcifications, cysts, and hyperostosis. 2016 WHO classification identifies 16 subtypes of meningiomas, with most of them being a low-grade grade 1 tumors, with atypical variety being identified as grade 2 and anaplastic papillary and rhabdoid subtypes being grade 3. Meningiomas are located most commonly in parasagittal location or along the suprahemispheric convexities and sphenoid ridge. They can also be observed along the floor-ventrocranial fossa, along the olfactory group, and in paracellular locations. Less common locations include CP angle cistern, clivus, intraventricular, and involving the optic nerve sheath or in the region of the pineal gland. Coronal T1 weighted CT image demonstrates prominent calcification of a mass in the midline along the floor-ventrocranial fossa. Non-contrast sagittal T1 weighted image demonstrates an iso-intense mass along the floor of the enterocranial fossa, consistent with an olfactory groove meningioma. Axial T1 weighted images post-contrast demonstrates a large extraaxial mass within left side of the posterior fossa along the left cerebellar hemisphere convexity. T2 image demonstrates the mass to be positioned posterior to the left internal auditory canal, consistent with a meningioma rather than a vestibular schwannoma at the CP angle cistern. This is a different patient, again demonstrating an iso-intense mass on T2 images with prominent homogeneous enhancement post-contrast T1 weighted image along the left occipital bone and posterior to the left cerebellar hemisphere convexity, which is prominently displaced anteriorly by the mass. Post-contrast T1 weighted coronal images demonstrate prominent homogeneous enhancement of this mass. In a different patient, the meningioma manifests itself predominantly as an intraosseous mass with prominent hyperostosis and thickening of the calvarium involving left temporal and inferior parietal bone. Post-contrast T1 weighted coronal and axial images demonstrate prominent enhancing extraaxial mass along the inner table of the left temporal and occipital bones with thickening of the adjacent cerebral tentorium consistent with a meningioma. In a different patient, homogeneous enhancing extraaxial mass along the posterior convexities of the occipital lobes bilaterally demonstrates invasion into the very posterior segment of the superior sagittal sinus. Hemangioblastomas are typically found in adults with peak incidence during 4th and 6th decades. They are uncommon tumors representing only 1 to 2% of primary CNS tumors. They are most commonly found in the cerebellum, spinal cord, and medulla. Supratentorial lesions do occur but are rare. They can be multiple in approximately 10%. 10 to 20% occur with von Hippel-Lindau syndrome. Hemangioblastomas are cystic in 60% and solid in about 40%. They are benign tumors made of thin-walled blood vessels with islands of mesenchymal angiogenic stromal cells. They typically demonstrate prominent enhancing mural nodule or enhancing solid mass on CT, MRI, and angiography. T2-weighted axial image demonstrates a cystic mass with an intermediate isointense mural nodule, which demonstrates prominent enhancement on post-contrast T1-weighted image consistent with a hemangioblastoma. Sagittal T1-weighted images obtained post-contrast again demonstrate a predominantly cystic mass with an enhancing mural nodule. Post-contrast T1-weighted axial image demonstrates a combination cystic and solid enhancing mass along the inferior aspect of the fourth ventricle. Pseudoangiography with a vertebral artery angiography demonstrates prominent vascular blush corresponding to the enhancing nodule, with demonstration of additional nodules within the upper cervicospinal canal and along the superior aspect of the cerebellum, consistent with multiple hemangioblastomas in this patient. Schwannomas. Schwannomas arise from Schwann cells, and the tumors are encapsulated and arise eccentric from the parent nerve. The tumors demonstrate both compact Antony A and loose Antony B pattern of organization. They can be associated with fatty degeneration, cystic changes, and intratumoral hemorrhage. They can be found in patients with both neurofibromatosis type 1 and type 2. Neurofibromas are unencapsulated masses which arise from within the substance of the parent nerve. They are composed of Schwann cells and fibroblasts. They show little tendency for degeneration or hemorrhage. These tumors show areas of organization resembling compact Antony A pattern. Axial T1-weighted image post-contrast demonstrates a prominently enhancing extraaxial mass within left cerebellopontine angle cistern with areas of cystic or necrotic degeneration. Image also demonstrates a small focus of enhancement in the region of the fundus of left IAC. This is consistent with a vestibular schwannoma. Axial T1-weighted image without contrast, axial T1-weighted image with contrast, and an axial T2-weighted image demonstrates a well-circumscribed T2 hyperintense mass in the region of the first genu of right facial nerve canal, with the post-contrast T1-weighted image demonstrating prominent homogeneous enhancement of this lesion, which was shown to be a facial nerve schwannoma. Pineal region tumors include pineocytoma, pineal parenchymal tumor of intermediate differentiation, pineoblastoma, and papillary tumor. Pituitary region tumors include pituitary adenoma, craniopharyngioma, granular cell tumor, pituicytoma, and spindle cell oncocytoma. T1 post-contrast coronal and sagittal images demonstrate a large cellular and supracellular mass with lobulated contour extending cranially, causing compression of the left basal forebrain and medial aspect of left temporal lobe. This represents a very large pituitary macroadenoma. Germ cell tumors. There are multiple subtypes, including germinoma, teratoma, yolk cell tumor, embryonal carcinoma, choriocarcinoma, and mixed germ cell tumors. Coronal T1 weighted image without contrast demonstrates predominantly isointense suprasellar mass in this child, with T2 weighted axial image demonstrating slightly hyperintense mass with irregular areas of hyperintensity, possibly representing areas of cystic changes, with posterior extension into the interpeduncular cistern, which is prominently enlarged, with compression of the anterior aspect of midbrain. Craniopharyngioma is a WHO grade 1 neoplasm. There are two major subtypes, adamantonomatous and papillary subtypes, with bimodal distribution in the first and second decade and fifth decade. The papillary subtype is most commonly seen in adults. The adamantonomatous type typically consists of a solid mass with calcifications and cysts, while the papillary type typically presents as a solid mass with calcifications and cysts being uncommon. Sagittal T1 weighted images through the brain before and after contrast administration demonstrate a complex cellular and supracellular mass with inferior component representing a solid component with prominent enhancement, while the superior component represents a complex cyst. Axial T2 and post-contrast T1 weighted images demonstrate hyperintense T2 signal of the solid component, which demonstrates, again, prominent post-contrast T1 enhancement and non-enhancing cystic component, consistent with a pediatric adamantonomatous type craniopharyngioma. Pineoblastoma is a WHO grade 4 tumor which is highly cellular and demonstrates isodense to hyperdense CT characteristics. On MRI, on T1 and T2 images, it tends to be isointense to gray matter and demonstrates hyperintensity on DWI due to its hypercellularity with prominent enhancement on post-contrast T1 weighted images. CT with contrast demonstrates slightly heterogeneous enhancing midline mass in the region of the pineal gland. MRI demonstrates isointense mass associated with prominent hydrocephalus in the region of the pineal gland. Post-contrast T1 weighted image demonstrates prominent enhancement of the pineal gland mass, which is isointense to gray matter on the pre-contrast image. The peak incidence of CNS lymphoma is in the 5th and 6th decade. It can be found in younger patients who are immunocompromised. Intracranial lymphomas are usually a primary large B-cell type that can present as a localized mass or sometimes as an infiltrative neoplasm. They occur in the perivascular location, and a special subtype of intravascular lymphoma can present clinically with multifocal strokes rather than as a dominant mass. Axial T2 weighted image demonstrates a hyperintense edema surrounding a more intermediate signal intensity mass in the left anterior parietal region. Perfusion MRI demonstrates elevated cerebral blood volume consistent with a vascular mass, which was proven to be a lymphoma. The last category is cysts and other tumors, and it includes arachnoid cyst, epidermoid cyst, dermoid cyst, colloid cyst, hamartoma, and lipoma. Epidermoid tumor is an ectodermal inclusion cyst with simple stratified squamous epithelium with keratin debris and cholesterol crystals. It does not contain any dermal component. It represents less than 1% of primary brain tumors and typically are found in the fourth through sixth decades. Typical locations of epidermoid tumor include CP angle cistern, paracellar region, middle cranial fossa, or diploid space. It frequently extends along CSF spaces. Sagittal T1 weighted image demonstrates a large mass in the region of the cistern of elemental postum, causing anterior displacement of the region of the pineal gland and the posterior commissure, along with a mass effect on the quadrigeminal plate and compression of the cerebral aqueduct. Diffusion-weighted image demonstrates a large, slightly irregularly shaped lobulated mass corresponding to the mass on the T1 weighted image with prominent diffusion hyperintensity, which is a hallmark of an epidermoid tumor. In a different patient, we see a hypointense mass on T1 weighted image, which is slightly higher signal intensity than that of CSF within the fourth ventricle with extension caudally through foramen magnum with deformity of the posterior aspect of the medulla and upper cervical spinal cord. The axial image demonstrates a slightly heterogeneous internal signal within this mass. T2-weighted image demonstrates prominent hyperintensity, and a post-contrast T1 weighted image demonstrates no appreciable enhancement. In a different patient, there's also a hypointense mass on T1 weighted image, which extends out through foramen Luschka bilaterally on these T1 weighted axial images, with prominent hyperintensity on T2 weighted images similar to the signal of CSF. In a different patient, near the vertex on T1 weighted image, there is a hypointense mass with a signal similar to CSF in the right parasagittal location, possibly smaller on the contralateral side, with a diffusion-weighted image demonstrating prominent hyperintensity of these lesions, again consistent with an epidermoid tumor. Dermoid tumors also arise from squamous epithelium with keratin debris and liquid cholesterol, but dermoid tumors contain dermal components such as hair follicles, sebaceous, and sweat glands. They are uncommon, but when they do occur, they're typically midline tumors, and occasionally they can rupture, spilling fatty contents into the subarachnoid space. They can also be found in the spinal canal and within the posterior fossa. CT images demonstrate somewhat atypical dermoid tumor that's off midline in the region of the right middle cranial fossa with peripheral calcification, with prominently low density within the mass, similar to that of fat, and the findings are consistent with a dermoid tumor. This is a patient with T2 weighted and proton density weighted axial images demonstrating prominent hyperintensity of this lesion. Colloid cyst is an endodermal cyst with cuboid and columnar epithelium that are found along the anterior aspect of the third ventricle, adjacent to foramen Monro. The density and signal intensity of the lesion can be variable depending on its content. It can potentially cause intermittent hydrocephalus and clinical symptoms. They're usually found in young adults. Axial T2 image demonstrates a small, subtle, minimally hyperintense lesion along the anterior aspect of the third ventricle, adjacent to the left foramen Monro. The lesion demonstrates hyperintensity on T2 flare-weighted images and hyperintensity on non-contrast T1 weighted axial image. Post-contrast sagittal T1 weighted image again identifies the lesion to be at the anterior aspect of the third ventricle without significant enhancement. In a different patient, we have a larger lesion, which is isointense to gray matter within the third ventricle, associated with hydrocephalus. Pre-contrast T1 coronal images again demonstrate prominent hyperintensity of this lesion, and sagittal post-contrast image again demonstrates no additional areas of enhancement. Imaging in acute stroke. We have multiple different types of studies that can be used to assess a patient with acute stroke, which starts with brain CT without contrast, perfusion brain CT, CT angiogram, brain MRI with diffusion wave imaging, perfusion brain MRI, and MRA. There have been significant paradigm shifts in the management and treatment of patients with acute stroke. The first shift occurred in the mid-90s following the report of the NINDS trial, which demonstrated superiority of IVTPA treatment for acute stroke patients versus placebo. The second paradigm shift occurred in the late 90s into the 21st century with intraarterial interventions, initially with thrombolysis, then followed by thrombectomy procedures. The third paradigm shift consists of physiologic brain imaging, either using brain perfusion CT or brain perfusion MRI. Information about the perfusion state of the brain at the time of presentation is vital in guiding management plans and appropriate utilization of resources, and help avoid futile efforts or setting unrealistic expectations. It can also help avoid complications such as reperfusion hemorrhage, arterial injury, or emboli into new territory, and ultimately the information can help improve patient outcome. Perfusion brain CT is typically done with a bolus injection of 50 mL of iodinated contrast material, with coverage either including the entire brain or mostly the supratentorial brain, with generation of multi-phase time density curves. Using first-pass kinetic model and deconvolution, cerebral blood volume, cerebral blood flow, MTT, and Tmax values can be calculated, and color maps of cerebral perfusion can be obtained. These are images from a patient who presents with a history of chronic ischemic symptoms involving the left cerebral hemisphere. A non-conscious head CT demonstrates chronic volume loss with bilateral chronic ischemic changes, but they are much more prominent within the left cerebral hemisphere involving left frontal and parietal deep white matter and possibly along the anterior and posterior border zone areas. Perfusion CT was obtained, which included cerebral blood flow, cerebral blood volume, and mean transit time color maps. And what the perfusion CT images demonstrate are asymmetric perfusion of the right hemisphere versus the left hemisphere, with the right cerebral hemisphere demonstrating much more normal appearing perfusion, whereas the left cerebral hemisphere demonstrating discrete areas of significant perfusion defects at the border zone between the right anterior and middle cerebral artery territories and between the left middle cerebral artery and left posterior cerebral artery territories. But what is interesting in this patient is that the patient actually presented with chronic bilateral internal carotid artery occlusions. But the perfusion CT was able to demonstrate the relative difference in perfusion state between the right cerebral hemisphere, which was not symptomatic, versus the left cerebral hemisphere, which contributed to chronic left hemisphere ischemic symptoms. To illustrate the importance of understanding the perfusion state of the patient at presentation, there are two cases I'd like to share with you. The first case, a 65-year-old female presented with acute left MCA occlusion right hemiplegia, aphasia, and patient received IV TPA at 2.5 hours and obtained perfusion CT following that. Cerebral angiography demonstrated an abrupt occlusion of the proximal M1 segment of left MCA with no significant flow to the left MCA territory. Patient underwent thrombectomy procedure with subtotal recanalization and reperfusion of the left MCA territory. Patient experienced no extremity motor weakness following the treatment with only minimal residual speech difficulty and was able to care for herself with an MRS score of 2 at 2 months. This was considered clinical success. The second patient presented following a pneumonectomy with acute right hemiplegia and aphasia, again with the left MCA occlusion. Due to the recent surgery, patient was not an IV-TPA candidate. In the angio suite, patient was discovered to have, again, a large clot in the left MCA with a proximal M1 occlusion. The left MCA and its territory were successfully recanalized following the intervention. Despite recanalization, patient went on to complete the stroke with no significant functional improvement and poor clinical outcome. The explanation behind the two different clinical outcomes of these two patients can be ascertained by the evaluation of the perfusion CT images. In the first patient with a good clinical outcome, patient had a relatively small core infarction as defined by the cerebral blood flow color maps with a large area of ischemia on the Tmax map, suggesting there was a large area of salvageable ischemic penumbra. This big mismatch resulted in good clinical outcome following a successful recanalization. However, in the second patient, at the time of presentation, the cerebral blood flow map images already demonstrated significant areas of core infarction involving the basal ganglia, the deep white matter, as well as posterior frontal and anterior parietal lobe cortex, which meant there was smaller area of mismatch and smaller area of ischemic penumbra, which resulted in poor clinical outcome. The takeaway lesson here is that the long-term clinical outcome for the patient depends on the perfusion state of the parenchyma at the time of presentation and treatment, and not just the arterial morphology. It's not just about the pipes, but more about the parenchyma. MRI can and are being used in the assessment of patients with acute stroke. Diffusion-weighted image remains the gold standard for diagnosis of acute stroke, whether they are small or large, and it is unmatched by CT, CTA, or perfusion CT. It is also the best way to identify and estimate the volume of core infarction at the time of presentation. Perfusion MRI can also be obtained, just like perfusion CT, to assess the perfusion status at the time of presentation. Two common techniques are available for perfusion MRI: dynamic susceptibility contrast technique and arterial spin labeling technique. Dynamic susceptibility contrast technique requires injection of gadolinium contrast, just like perfusion CT, which requires an injection of iodinated contrast material. Relative cerebral blood volume, mean transit time, and cerebral blood flow information can be obtained using the DSC technique. This slide shows color blood flow images from a DSC perfusion MRI, demonstrating symmetric cerebral perfusion in both hemispheres. In this slide, the MTT map in grayscale demonstrates a delayed mean transit time within left posterior cerebral hemisphere. The cerebral blood volume map demonstrates decreased cerebral perfusion, consistent with area of perfusion abnormality. Perfusion MRI using ASL technique is a non-contrast procedure which allows for repeat acquisition if needed. It generates quantitative CBF values, which with abnormal DWI volume can be used to identify presence of mismatch and estimation of ischemic penumbra volume. This slide demonstrates color ASL perfusion CBF images demonstrating symmetric cerebral perfusion. In the setting of acute stroke management, there are certain key questions that need to be answered. First question is, does the patient have a stroke? And if so, is it a large stroke, small stroke, or lacuna infarct? Does the patient have a large artery occlusion? Does a core infarction exist? And if so, what is the volume? Does ischemic penumbra exist? And what is its volume? Answers to these questions can be obtained by both CT and MRI technologies. However, in identification of small as well as large strokes, MRI is superior to perfusion CT and CTA. Assessment for a large artery occlusion is similar between MRA and CTA, but core infarction volume identification and estimation is better with DWI MRI, which is the gold standard, versus perfusion CT. Identification of ischemic penumbra is likely similar between perfusion MRI and perfusion CT. Currently, CT is much more commonly used for assessment of acute stroke patients. Head CT without contrast, head and neck CTA, and perfusion brain CT have become the standard at many institutions. However, these studies are associated with significant radiation dose and contrast exposure. Inappropriate utilization is becoming an issue for patients presenting with relatively low NIH stroke score who are unlikely to have a large artery occlusion. MRI is more sensitive and specific for identification of acute small infarctions and core infarction volume. No radiation or iodinated contrast exposure is needed. Acquisition time is becoming shorter. I expect a move toward increased use of MRI in the acute imaging of stroke patients. Thank you very much for your attention. This is the end of the lecture.